I appreciate everybody attending. For those who I haven't met, my name is Matt Lillyblad. I'm a clinical pharmacy specialist for cardiology and critical care here at Abbott Northwestern Hospital. And so that specialist role is a leadership role within the pharmacy department. I'm kind of analogous to our clinical nurse specialists, where there's a little bit of patient care responsibility. I have the opportunity to round with the advanced heart failure section with the shock service in the ICU, but also a lot of quality, policy, protocol management, education, et cetera, not only for the department but outside the department, kind of in the realm of cardiology. So it's really a pleasure and an honor to be here today to talk about a topic that I'm particularly passionate about. I was a graduate of pharmacy school in 2010 and did 2 years of pharmacy residency here, one in cardiology between 2010 and 2012. It was a very dynamic time period for dual antiplatelet therapy with the advent of prasugrel and ticagrelor and the approval of those in the ultimate implementation. And it really sparked an interest and a passion for dual antiplatelet therapy. And I would say in the last 10 years, it's been equally dynamic now that we have multiple therapeutic options for dual antiplatelet therapy and ways to potentially de-escalate. And so that's what I'm going to be talking about today. I have no relevant financial relationships. I only get paid by a line of health. In the interest of time, I'll bypass the objectives, but here are the objectives for your reference. And so I did say across ASCVD, this isn't going to be an 8-hour symposium on ASCVD, so I do have to narrow the scope of the topic here. And so really the focus is going to be related to acute coronary syndromes and chronic coronary syndromes in patients who receive percutaneous coronary intervention. And that's really the area where the literature has been dynamic since 2012, and it will be the focus on the discussion today. So some background here, I'm preaching to the choir a little bit, but antithrombotic therapy has really been the cornerstone of the treatment of chronic coronary syndromes as well as acute coronary syndromes since the 80s. And we found the value of aspirin, we found the value of heparin. More recently, since the mid-2000s, dual antiplatelet therapy with aspirin and a P2Y12 inhibitor, has become the gold standard, particularly in patients who receive PCI. And so we had ticlopidine that was initially approved and studied, and fortunately, the second generation thienopyridine, clopidogrel came out because ticlopidine had a high risk of aplastic anemia, TTP, some other kind of blood dyscrasias associated with it. And so Plavix really became the standard of care, the gold standard post-PCI because of its reduction in myocardial infarction, as well as the protection of those stents that were placed. Since about 2007, we've had more data around more potent, newer antiplatelet therapies related to P2Y12 inhibition with prasugrel and ticagrelor coming to the market in the early 2010s. And so despite the immense value of these agents, bleeding remains a concern. And so that's really going to be the focus on when we talk about de-escalation today. And so in major bleeding, if you look at the randomized controlled trials, depending on definition and the potency of the agent, used between 1 to 10% at 12 months. In the more observational studies, it's naturally a little bit higher with more high bleeding risk patients being included in real world with a 2.8 to 11% observational risk. Again, those are highly dependent on what we use to define the bleeding, the potency of those agents, and really the enrolled population. Thankfully, fatal bleeding is relatively rare, so probably less than 0.5% even with the more potent agents and closer to 0.1% with clopidogrel. But that bleeding risk is high, especially if you compare it to other antithrombotic strategies outside of the coronary world. And so I think there's times where people feel that dual antiplatelet therapy is kind of a light antithrombotic action. But what we know from that is from observational studies, the bleeding is actually prevalent and higher than a lot of oral anticoagulation in the outpatient setting. And so anything we can do to mitigate that risk is a potential value to these patients because there's implications of bleeding that go beyond the bleed itself, beyond the loss of blood. And so what we find in the PCI population is in patients who do have a major bleeding, there's studies that show a 3-fold increased risk of MACE, 4-fold increased risk of MI, a reduced quality of life, even with just the nuisance bleeding, and most notably, an increase in mortality, which is particularly concerning. And that mortality range is obviously highly dependent on the severity of the bleed itself. This was an interesting study from Tracer This tracer was a Braxapar study, but they wanted to look back and utilize that patient population, kind of model that patient population to see what was the influence of MI on mortality after 30 days and what was the influence of bleeding on mortality after 30 days. Because really our focus of utilizing antiplatelet agents is to reduce that MI, and that can sometimes be our focus in getting these agents on board. You can see obviously reoccurrent MI is gonna be a substantial contributor to mortality, again, beyond that 30-day mark. But what's particularly interesting was how that the bleeding also was a huge influencer. And is that the bleeding severity rose with BARC, based off BARC criteria. It had more and more influence on mortality, and not surprising when you got to BARC 3C criteria, which is intracranial hemorrhage, it was a huge influence on prognosis and mortality. And so with this, if we can mitigate some of the bleeding risk while maintaining the ischemic benefit, there's gonna be a lot of value to our patients. And this is a quick slide on the kind of those mechanisms. So really, it's rarely, like I said, the bleeding itself that kills the patient. It's our response and the body's response to that bleeding that probably contributes to the mortality that we see. So we got this, anytime we're talking about antithrombotic therapy, we got this balance, right, of prevention of thrombosis that we're trying to provide, but also the avoidance of bleeding. And it's really a tightrope walk in a lot of our patient populations, and something that we should really continuously reevaluate. And so because of much of our studies were done, early 2000s, mid 2000s, there's always value of reassessing whether the risk benefit of those therapies or the way we use those therapies then still are valuable today, right, in 2025. And so in 2025, we have improved stent technology. We have improved procedure technology, particularly with intravascular imaging. We have improved secondary prevention strategies where the risk of MI might be lower just at baseline because of how well we managed patients' comorbid diseases. We are more brave to do PCI in higher bleeding risk populations. And so we need to reassess the risk benefit there. We have those more potent antiplatelets like we talked about. And really, we got to look for an opportunity for regimen simplification. As a pharmacist, people joke that you're all about the drugs. Well, I actually get more. I feel better about getting a drug discontinued more than adding another med. And these patients with cardiovascular disease have so many comorbidities, and every time we turn the corner, there's another med that shows value, and that med was studied as an add-on to the existing baseline regimen. It is nice when we can simplify a patient's regimen based off of the advances that have been made over the last 10, 15, 20 years. The other piece of this is that the ischemic and bleeding risk is not stagnant, and we've learned this across several different studies, exploring over time after that intervention, what is the bleeding risk and what is the ischemic risk at different time points. And so what has been pretty consistently found is that very early on, the ischemic risk is very high, prohibitively high to not be on dual antiplatelet therapy. But as the time goes on, particularly at that 3-month standpoint, there might be an equalization of risk of bleeding and thrombotic risk. The thrombotic risk seems to fall over time, whereas the bleeding risk is high early, falls, but then stays pretty consistent over the period of time. And so when we think about antithrombotic therapy, dual antiplatelet therapy duration particularly, do we really need the quintessential 12 months that everybody remembers, right? I could walk out into the halls right now, find a pharmacy student in their second year of school, just finished up their cardiovascular pharmacotherapy course. They might not remember anything except for 12 months for drug-eluting stents, And so, it is ingrained into our heads, but there's an opportunity here to reevaluate whether 12 months is truly the correct duration for everybody, based off of this kind of evolving thrombotic and bleeding risk. And, again, there's at least 3 to 4 studies that have looked at this. And this is just one of them. It was almost 20,000 patients in the BLEMAX and RENAMI registries looking over time. And the trend isn't clean, but you can kind of see that the thrombotic risks start to dip really in that 3 to 4 month time period. And then there's basically a trade-off between bleeding risk and thrombotic risk from there on out. So there's multiple factors that influence bleeding risk with DAP, right? There's the patient-specific baseline factors. And unfortunately, we really can't do much with that, right? We can put somebody on a PPI, which is advised in the guidelines to reduce the risk of GI bleeding. We can control their blood pressure to lower the risk of intracranial hemorrhage, but there's really not a lot we can do from a patient modification standpoint or modifying risk factors for that bleeding risk in the patient. There are things that we can do with the antithrombotic therapy to potentially mediate that risk. And so the number of antiplatelets and antithrombotics on board, the potency of those antiplatelets, and the duration that we use those antiplatelets in can all influence the bleeding risk of DAPT. Excuse me for 1 second here. Too much caffeine this morning. So when we talk about de-escalation, which is the focus of this talk, there's basically 3 different ways we can de-escalate DAPT. So we can either switch, so move from a higher potency agent to a lower potency agent. We can dose reduce any of those agents, or we can discontinue one of the two of the dual antiplatelet therapy, whether it be the aspirin or whether it be the P2Y12 inhibitor. The focus of this talk is really going to be on switching and discontinuation. There is some dose reduction strategies out there, both empiric and guided by platelet function testing. I don't think that the results are interesting, but not necessarily practice changing. And I think if you read the most current guidelines, they would agree with that because the dose reduction is not incorporated in those guidelines at all. So I'm going to, in the interest of time, going to omit a discussion on those, but really focus in on the switch and the discontinuation, which is now starting to pump up in the guidelines that we have from AHA and ACC. So since 2012 to 2014, this is the number of studies that have been published regarding de-escalation of dual antiplatelet therapy. So that's 25 studies in 12 years. Now, I'm a person who tends to try to under-promise and over-deliver, but I stood up here and told you I was going to demystify 25 studies that have happened in 12 years. And despite having those 25 studies, we don't have necessarily any rules of thumb yet, somehow, some way, but we do have ideas. And so I might have bit off a little bit more than I can chew, but I'm going to try to do my best at a high level, fly over kind of all the studies that have been published, where they land in kind of the spectrum of de-intensification. Or de-escalation, and then hopefully we can come to bring some ideas to the table at the end of this talk. All right, so the first form of DAPT de-escalation I'm going to talk about is the discontinuation of this. So that's either aspirin or the P2Y12 inhibitor. So like I said before, ingrained into the guidelines since really 2007 is the basically 1A or class 1 recommendation around DAPT duration, particularly in acute coronary syndromes being 12 months. And your reiteration versus iteration of those guidelines, that recommendation has really been carried forward up until even today. The 2025 ACS guidelines from AHA just came out in the last month or so, and again, they gave a 1A recommendation for the continuation of dual antiplatelet therapy for 1 year to reduce MACE, right? And there's 6 citations that are associated with that. Note that this recommendation is not necessarily specific to patients who get PCI. This is all-comer ACS, right? PCI, medically managed, and CABs. But when you look at the PCI, the PCI citations that are a part of this, this recommendation, they all go back to CURE, which is one of the original clopidogrel trials, only 20% of patients that got PCI. Triton, which was our prasugrel landmark clinical trial, and Plato, which is our ticagrelor clinical trial. But interestingly, in those trials, the majority of patients actually did not get 12 months of therapy, right? So in CURE, they allowed for 3 to 12 months, but the median duration of use of clopidogrel was 9 months. For Triton, the median was 15 months, and the Plato was back to 9 months. Also, within those trials, there was no comparison of DAPT duration in there, right? They gave a kind of a guideline around the duration of use, but let the people caring for the patients ultimately decide the duration of therapy. And even if you go to the fine print of the CURE trial and the investigators themselves, they say the exact duration of therapy cannot be deduced reliably from a trial with the design of CURE. The only way to reliably estimate the exact length of time the various treatments in any condition should be given is by prospectively randomizing patients to different durations of therapy. So I'm not saying that what we've been doing for 20 years is wrong, but it's not necessarily based off of clinical trials that were designed to determine the correct duration of dual antiplatelet therapy after PCI. And so kind of the core tenets of DAP discontinuation when we talk about this plethora of studies is focusing on which agent, when, was it acute coronary syndrome or chronic coronary syndromes, given the different ischemic risks and the ultimate bleeding risk of the patient population. And so when we talk about this first section is going to be in the acute coronary syndrome population, abbreviated DAP. So this is looking at the P2Y12 discontinuation and aspirin continuation at various time points compared to 12 months of DAPT. We have 3 studies. You'll see a common theme is these studies are pretty good sized, even though they can arguably be underpowered for ischemic events, and we'll talk about that and some of the limitations of the studies. These are pretty solid trials when it comes to patient populations enrolled. And so going to aspirin monotherapy was studied at 6 months in the SMART data and DAP-STEMI, and at 3 months at the reduced trial. What you can see here is in the SMART data, unfortunately, even though MACE was not non-inferior, the individual outcome of MI was significantly increased with moving to aspirin. With DAP-STEMI and reduced, there were similar ischemic event rates. Interesting, though, in this population that the risk of bleeding was not mitigated at any point with going to aspirin therapy, which is kind of hard to fathom, but was what was seen in the clinical trial. If you're looking for like the one-liner for each of these slides, I've color-coded, in my opinion, what ultimately the trial represents in terms of, does it support the therapeutic regimen that was studied? Is it uncertainty, or was there harm with it? And so here, really, there's a lot of uncertainty, particularly on the fact that bleeding risk wasn't reduced. And with that SMART date trial being a signal of increased in MI with, again, going to aspirin monotherapy. Going to P2Y12 inhibitor monotherapy in the acute coronary syndrome population was very much a different story. And so you can see here that the transition to single agent therapy with a P2Y12 happened earlier across the board, with the longest duration being 3 months and the shortest duration in TPAS actually being less than a month. So the median duration there was actually at 14 days, they dropped the aspirin and went to ticagrelor. You can see a lot of potential value here in both maintaining the ischemic outcomes that we desire, but reducing the bleeding risk. And the common theme amongst that is the use of a high potency agent. So ticagrelor really was the common theme here. The one clopidogrel trial, again, I'm talking specifically for acute coronary syndrome, unfortunately saw an increase in MACE and an increase in MI with the reduction of bleeding trade-off. And you can see here these trials, again, in acute coronary syndrome, a relatively high-risk population, the move to monotherapy with a high potency agent, again, ticagrelor being the most represented agent, appears to have some value there. Now moving to the trials that were a combination of chronic coronary syndromes and acute coronary syndromes. And so that is actually the majority of the data that is out there. If you look at the spread between the trials, they generally were about a 50-50 split, and in some it was 60-40 more than the chronic coronary syndromes as opposed to the acute. A lot of these trials are the earlier studies. And so the earlier studies were more conservative in their patient enrollment, particularly with ischemic risk. And so they're the ones that had the limitations in terms of procedural or angiographic or procedural considerations, where someone couldn't get complex stenting necessarily and be allowed to be enrolled in these studies. So when they talk about the populations, the populations of low ischemic risk, this is really what we're talking about here. And so there's 6 studies looking at 6 months dropping to aspirin alone. A lot of difference in no difference in ischemic outcomes, but really not much influence on bleeding risk either. And again, this is really low event rates for both the ischemic outcomes and the bleeding outcomes across the board here. So not a whole lot of certainty, I would say, in the outcomes of the trials. There's a few more trials here that looked at conversion over at a more recent time point. So utilizing clopidogrel and aspirin for either 3 months or 1 month, and then moving to aspirin monotherapy there afterwards. And again, a lot of no difference here. Master DAP is particularly interesting. It's one of our more contemporary trials. It's one of the larger trials looking at this. But it was one of the first to really took a hard look at the high bleeding risk population and utilizing again, DAP therapy for that 1 month, and then after 1 month dropping to either aspirin or clopidogrel. So it could be either or as a monotherapy strategy. Again, maintaining ischemic outcomes, but reducing the bleeding risk outcomes. So we're going to talk more specifically about the high bleeding risk population here in the upcoming slides. But I think there's a reason here why this kind of sticks out as a potential influential study in terms of our de-escalation strategies, again, for this mixed population of chronic coronary syndromes and acute coronary syndromes. Now moving to the P2Y12 inhibitor monotherapy realm, you can see here that at various time points, varying from 1 month to 3 months, the de-escalation to either ticagrelor or clopidogrel was, at the very least, equivalent ischemic outcomes, and it's seemingly a reduction in bleeding in the majority of those trials. So again, moving to that P2Y12 inhibitor monotherapy seems to stick out a little bit in terms of its value in de-escalation through dropping one of our antiplatelets that we typically lose with aspirin, again, before that 12-month time span. A little distortion here, my apologies. So at that point, we just talked about abbreviating, right? Abbreviating the duration of DAP and either dropping the aspirin or dropping one of the P2Y12 inhibitors. There's also an opportunity to de-escalate through de-intensifying when we have different agents of different potencies. And the rationale really behind this is that what we found in our landmark clinical trials of the more potent antiplatelet agents, the bleeding risk was higher. And unfortunately with prasugrel, even the fatal bleeding risk was found to be higher. And so if we can utilize a high potency agent during the period of time of highest ischemic risk and then de-escalate to something at lower bleeding risk, there might be value there from a bleeding standpoint. There's 2 ways of doing this. We can do it unguided, which means we just are planned, right? So at 1 month or at 3 months, we are going to drop the ticagrelor or the prasugrel down to Plavix, or clopidogrel, excuse me. Or there's guided, so either through platelet function testing or through genomic testing to assure that when we move to the clopidogrel, that there's going to be the therapeutic effect that we anticipate. We know from clopidogrel is highly influenced by not only genomics, but other concomitant disease states where there's a proportion of patients that remain basically uninhibited or high platelet function testing. And so on the genomic side, we can overcome that. But on the disease-specific side, there's high BMI, there's diabetes, there's chronic kidney disease. Those are all concomitant diseases, which are common, concomitant diseases that are common in coronary syndromes that can put a patient at higher risk of not responding to Plavix, even though their genomics might be just fine. And so those are kind of the 2 strategies around the guided de-escalation. Here, I want to first talk about the guided. And so TOPIC was a study that for the first 1 month, they allowed for prasugrel to ticagrelor. It's about 50-50 between the 2. And then with a planned at 1 month de-escalation to clopidogrel for the remaining 11 months. And what they found was no different ischemic outcomes and a reduction in bleeding with that strategy. TALOS AMI was a more specific AMI trial, used ticagrelor alone, only used ticagrelor as part of DAPT for the first month with, again, a de-escalation to clopidogrel without any sort of assessment of genomics or platelet function testing. Again, no difference in ischemic outcomes and a reduction in bleeding there. The guided strategies are particularly interesting, I feel like, I think an ever-evolving field now. So the 2 most notable studies are TROPICAL, which is based off of platelet function testing using multiplate, or the Popular Genetics, which utilized genomic testing to determine whether a patient could be eligible for the clopidogrel. And so with that multiplate de-escalation at 2 weeks, what they did was they spent the first week on prasugrel. They spent the second week on clopidogrel. They checked the platelet function testing on clopidogrel, and if it was solid enough, so I think their threshold was 46 or 48 units, they just remained on clopidogrel. If they weren't a clopidogrel responder, regardless of the rationale behind it, they switched back to the prasugrel. What they found was no difference in ischemic outcomes, but there was also no difference in bleeding. In the genetics, they use genotype testing up front. And so for the patients with the loss of function alleles to CYP2C19, that's our metabolic pathway for the activation of clopidogrel, because clopidogrel is one of the agents that require activation, and it's heavily genetically different across the world. If they had the loss of function allele, they used prasugrel or ticagrelor. Otherwise, they were clopidogrel eligible. And there, they found no difference in ischemic outcomes, but less bleeding with getting the opportunity to use clopidogrel offered the population as a whole less bleeding. This is a little out of scope of this presentation, but it's always the reminder that I want to throw out there is if you're talking about utilizing this strategy of de-intensification, particularly if you're going from ticagrelor to clopidogrel, that the clopidogrel is going to need a reload, right? So the offset of ticagrelor, the patient becomes, ticagrelor is a reversible inhibitor of P2Y12, and so its offset is much faster. And the clopidogrel onset, if you do not use a load, is 7 days. And so there's a time period between probably day 3 and day 5 or 6 where you're going to be under-inhibited in terms of your P2Y12 inhibition if you don't provide that load. And so in this patient population, I would heavily encourage a load of clopidogrel at the time of transition when moving from ticagrelor. Outside of 30 days, if you're doing this outside of 30 days with prasugrel to clopidogrel, there's no need for that load necessarily. And so because the duration of effect of prasugrel is much longer, it's an irreversible inhibitor, just like clopidogrel is an irreversible inhibitor. So you got that 7-day onset with a offset with a 7-day offset. So it's kind of a natural bridge in of itself. So now for the limitations, I'm not going to pretend that all these trials that were ever published were landmark clinical trials and that we should follow them verbatim, because there certainly are limitations. So the combination of ACS and non-ACS populations makes interpretability of otherwise large studies a little bit more challenging. These trials were often powered for the bleeding, since that's what we were really trying to influence here, with non-inferiority designs for the ischemic outcomes. And so anytime you have a non-inferiority study, there's limitations there. I will say that our studies looking at dropping aspirin and continuing P2Y12 inhibitors along with oral anticoagulations with AFib and PCI were non-inferiority style studies too. And I think we've clinged on those studies, and I love that we've clinged on those studies, and we do, I think, a great job here and probably outside of these walls in making sure that patients aren't on triple therapy for an extended period of time, but those were non-inferiority studies. Many of those were non-inferiority studies also. These patients tended to be a highly selected patient population. I think that's improved over the course of time. So if you look at the studies from like 2012 to 2016, when this concept was new, the studies were conservative, right? And when you go from 2016 though to 2024, 2017 to 2024, they were more inclusive of higher risk patients. You start losing the angiographic parameters that were exclusion criteria and welcomed basically all comers when it came to PCI complexity. Now that being said, it still takes somebody to enroll them in a study. And so whether there was subconscious or conscious bias towards not enrolling patients at the investigator level who were higher risk out of fear that they would get the abbreviated therapy and thinking that it wasn't well, we can't control that. And we kind of saw that with some of the event rates in some of the studies, that despite being allowed to enroll a higher risk population, the overall event rates were on the lower side. It was just something to keep in mind. And there is some generalizability concerns with some of the studies. So there's about a handful of studies that were done in like Taiwan and Korea, prospective, large, very well designed, very well executed studies. But what we know from the East Asian patients is that their ischemic risk and bleeding risk is actually different than others around the world. They're actually lower ischemic risk and high bleeding risk while on DAPT. And so that's going to be just a different risk profile in a specific population when all they're enrolling is patients from that ethnicity. All right, so we kind of ran through all the studies again at the high level. Is there a way that we can single out patients based off what we know now who would benefit the most and have the lowest risk associated with this de-escalation practice? And so what we know from these studies, what we know from a lot of the studies in this nice meta-analysis of 11 trials of over 9,000 patients at high bleeding risk is that there's a profound bleeding risk benefit in terms of major and non-major clinically relevant bleeding, reduction of 24%, a 20% reduction in major bleeds, actually, interestingly, a 21% reduction in cardiovascular death, no different in all-cause mortality, with no change in MACE. And so this was utilizing patient-level data from, again, those 11 clinical trials on DAP duration, or investigating DAP duration. And what they ended up using is either the precise DAP score with greater than or equal to 25 being considered high bleeding risk, or the HBR score. Which one you would use if you're interested in using one in clinical practice is probably 6-1, half dozen another. The guidelines talk about that high bleeding, the HBR score. It seems a little bit harder to use because it's just this laundry list criteria, and you have to meet 1 major or 2 minor, and no one's going to commit that to memory. Whereas the precise DAP has a nice calculator that you're able to utilize. It's just a few endpoints, although white blood count being in there is a little bit odd and may not be readily available in all of our patients, but certainly measurable. And I would say the precise DAP has been studied more prospectively in terms of assessing bleeding risk in the DAP population than the HBR score. But again, I think you could typically really utilize either one. But you can see in this high bleeding risk population, the bleeding risk value seems to be even greater than when you look at an all-comer population of varying bleeding risks. There's 3 studies that are looking at this, and I know it's controversial, but I gotta talk about it. Is assessing that bleeding risk in the setting of, as well as ischemic risk, and what should we put more weight in? Okay, so in this study, and again, there's 2 other ones, but this is a sub-study of the SMART date trials. This is one of those DAP duration trials. And what they did was they stratified patient based off of a precise DAP score of less than 25 or greater than or equal to 25. So this population here that I show in this graph is very low, or moderate bleeding risk. And what they found was there really was no difference in BARC 3 to 5 major bleeding when DAP was abbreviated, but there was an increase in MI, a combination of MI stent thrombosis and ischemic stroke was significantly different. Then when they looked at the high bleeding risk population, the major bleeding, BARC 3 to 5 was significantly influenced by the abbreviation of DAP, but there was no difference in MI stent thrombosis in ischemic stroke. And so there's a contingency out there who believe that we should disregard ischemic risk and predicate our DAP duration only solely on bleeding risk, because the high bleeding risk population sees the value in the reduction of bleeding, but in all the 3 of the studies that have been published, there was no difference in ischemic risk. That's a hard pill to swallow, to just ignore ischemic risk, especially with how high a risk population we can see, particularly within these walls. But I think it's just food for thought that maybe bleeding risk should be the forefront of our risk assessment. And then, of course, we can't just completely disregard ischemic risk, but patients, even at moderate ischemic risk, may still derive benefit without any risk of higher ischemic outcomes when we shorten that duration of dual antiplatelet therapy. There was also a meta-analysis here of its 5 clinical trials of over 20,000 patients that looked at PCI complexity, right? So they created a high complexity criteria for PCI. So here you can see either 3 vessels treated, greater than or equal to 3 lesions treated, greater than 3 stents implanted, over 60 millimeters total stent length, bifurcations, and CTOs were all considered that high-risk population, right? And these were all enrolled within the studies that I just talked about earlier, but they meta-analyzed those patients who met the criteria for high complexity and compared them to low complexity. And what they actually found here, again, high complexity patients still did not have an elevated hazard ratio for ischemic outcomes. And when compared to non-complex PCI, outcomes were very similar. But they did see a reduction in key safety endpoints, particularly major bleeding. And then if you look at like the net clinical outcomes, again, the overall value of reducing dual antiplatelet duration was evident, again, driven by the reduction in bleeding, but no difference in the ischemic outcomes. And so again, we have some very complex patients. I'm not going to stand up here looking in the eye and say, don't worry about the ischemic risk, their high bleeding risk, do something different. But I just want to kind of drive home the point that is that the abbreviation, the de-escalation of antithrombotic therapy can be tolerated in a population that's probably larger than what we had originally considered based off of baseline ischemic risk. I want a quick touch on the guidelines here because this is making its way into the guidelines now. And so as mentioned at the beginning of the presentation, this is the ACS guidelines from AHA-ACC that were just published about a month or two ago. Default strategy, they still say, is greater than or equal to 12 months. They do call out as a class 1 recommendation the abbreviation of dual antiplatelet therapy to ticagrelor alone in the acute coronary syndrome population, which I was kind of surprised that I believe the data was reproduced with going to ticagrelor monotherapy at 1 month. I feel like sometimes guidelines are a little bit conservative in implementing something that's been a thing for just a couple years preceding it. But nonetheless, they support moving to ticagrelor monotherapy and basically as a bleeding risk mitigation strategy. So not necessarily just high bleeding risk patients, but in any patient where you're trying to mitigate that bleeding risk. They do also talk about de-escalation strategy as a class 2 recommendation. So with that first month being with ticagrelor or prasugrel plus aspirin, and then doing the de-escalation down to clopidogrel for the remaining 11 months. And then that high bleeding risk population using aspirin plus a P2Y12 inhibitor, and then at 1 month dropping down to either aspirin or P2Y12 inhibition alone. We'll talk about this a little bit. That makes that 1 month time frame and still supporting aspirin as monotherapy in acute coronary syndrome population makes me a little concerned. You know, if I get it with moving to a more potent monotherapy at 1 month makes sense, because if you're providing more platelet inhibition with, say, a ticagrelor, maybe the value of aspirin added to that, it becomes less and less. But in terms of going clopidogrel monotherapy with only like the 40 to 50% platelet inhibition on its own, or just going to aspirin, you know, the data really doesn't support aspirin after 1 month in acute coronary syndrome, in my opinion. So I would probably extend that more out to like the 3 month time period and definitely use a P2Y12 inhibitor as monotherapy as opposed to the aspirin alone. And then our chronic coronary syndrome guidelines, we have the chronic coronary syndrome guideline from 2023, but then the 2021 revascularization guidelines that were pretty consistent in saying that, you know, at least 6 months of DAPT with a reassessment at that point. In our high bleeding risk populations, we can consider, you know, aspirin plus clopidogrel for 1 to 3 months, and then either clopidogrel or aspirin alone thereafter as a de-escalation strategy. All right, so kind of my final takeaways. I kind of just talked about this a little bit. I would be cautious about aspirin monotherapy in the first 6 months, particularly in acute coronary syndrome population. I think if we're going to de-escalate by dropping one of the agents, that we should drop the aspirin and continue the P2Y12 in the majority of those patients. If we're abbreviating DAPT in acute coronary syndrome, I think, again, ideally using that P2Y12 inhibitor monotherapy. And if you use ticagrelor, I feel pretty comfortable about that being as early as 1 month, just based off those studies. If you're on clopidogrel, maybe more of the 3 month time period or longer as a de-escalation opportunity. If you truly want to consider longer duration of DAPT and you've started out with a more high potency agent, we can strongly consider a de-escalation strategy at kind of 1 to 3 months, a de-escalation through de-intensification by transitioning off the ticagrelor or prasugrel to the clopidogrel with maintaining ischemic outcomes and reducing bleeding risk. And then if you're really concerned about, I would go to clopidogrel monotherapy, but I just want to make sure they're a responder. I think genomic testing is a very reasonable tool because, you know, up to a third of the patient population may be carry alleles for non-response. And so if you really want to make sure that clopidogrel therapy is, the patient is responsive to that therapy, at least from a genomic standpoint, we're able to do that here in a pretty reasonable time frame is my understanding, but the testing is available. And we can utilize that to give us kind of the oomph, the courage to make that transition if we're planning on doing it already. And what I'll end with is I think we should do away with the default. I'm not standing up here and saying that the de-escalation strategies should be used in every single patient. I'm not even saying that they should be used in the majority of patients, but I do not like the language in the guidelines around a default strategy. Because I feel like when we have a default strategy, then we have to try to manufacture excuses to deviate from the default. If we can't find a way to do that, then we're kind of stuck in the default mode. I think potentially a better practice is to not think of anything as a default, but to look at the patient. And that doesn't need to necessarily be pre-procedure. We can utilize the antiplatelet therapies that we want during the procedure, but a reassessment post-procedure and a reassessment as the patient goes on throughout their therapy. Here we did talk about patients who all had tolerated dual antiplatelet therapy for a period of time before being randomized and switched to whatever de-escalation strategy. But we have patients who don't tolerate, whether from a bleeding standpoint or elsewhere. I think this data is extrapolatable, and we should be constantly reassessing the risk of these patients over the course of the 12 months post-procedure to see if they weren't eligible or we don't think they were a good candidate for de-escalation before implementing it earlier on than that 12-month time period. But I think there's value in like looking at the patient and creating the therapeutic regimen based off of that and not necessarily having this default of 12 months that we've had stuck in our mind forever. That's all I got. Any questions? Yes, Dr. Starkey.
Hi, Matt. Thank you. That was really, really good. I appreciate the effort you put into it, and especially since it's like only 7 hours old now that you updated the data. But it seems to me, bleeding is such a broad endpoint. And I'm wondering if when you looked over all this literature, were there any themes on what kind of bleeding was it that was associated with the bad outcomes? Was it the spontaneous GI type bleeding or procedural related, or do we have that kind of granular information?
Yeah, it is out there. I know a lot of the studies that looked at that bleeding risk, they actually tried to start the assessment out at 30 days so that procedural bleeding risk, because that's a different animal, right? The bleeding in the first 30 days and the ischemic outcome in the first 30 days are so influential on prognosis. And so a lot of the assessments actually happen at the 30-day mark going forward to be in the more chronic therapy phase. The most common bleeding being GI bleeding, with intracranial hemorrhage being our most concerning, being relatively rare. And so I would say too that a common theme, if you look at the BARC bleeding criteria, major bleeding only hits when you hit BARC 3. And that's a transfusion-related endpoint. 3A is a transfusion endpoint. 3B is actual interventions along with the transfusions, and C is the intracranial hemorrhage. And the BARC 3B and the BARC 3C bleeding wasn't as influenced as some of the lower risk bleedings that were seen in those studies. So that's why, there's the idea, I talked about at the beginning that the mortality, or bleeding influences mortality. That's pretty profound when you look at the observational standpoint. But then when you go to these studies, granted, maybe not powered to do so, but we didn't really see that mortality benefit. That's probably because we're not preventing as maybe some, but not as many of those more severe bleeds as the more nuisance or less severe bleeds.
Yeah, that's a really good point. And then, have you looked at our information on what our compliance with PPI use is in this population?
I have not, but that'd be definitely an interesting thing, and it's well supported by guidelines and literature that, a lot of patients would meet that high-risk criteria for being on a PPI during their therapy, and then remembering to take it off when it de-escalates.
Well, there's been a couple of studies about doing P2Y12 monotherapy versus aspirin after the 12-month time period.
Yeah.
Which wasn't really the focus of today's talk. Which I think has convinced me to do Plavix a bit more, but I worry about not genetically testing any of these people.
Yeah.
What do you think of that strategy without genetic testing?
I think at that time frame, I think it's okay. And I think, I think genetic testing is a tool. And if you have a patient that's particularly high ischemic risk and you need another data point to convince you to de-escalate, I think that's an opportunity there. But I don't necessarily think it needs to be done in necessarily everybody. In terms of that 12-month point, that's interesting, right? Because it was kind of an all-comer population in those studies that looked at the extended therapy. And so I'm not sure that I would routinely genetically evaluate those patients, but it's something to chew on, I think. But yeah, it's interesting. I'm only talking about one side of a diversion here in the literature, right? So I talked about de-escalation, but there's also a lot of evidence about prolongation, right? So longer use of DAPT, using DAPA with a reduced dose of, say, ticagrelor, extending the P2Y12 monotherapy as opposed to aspirin, which we could probably consider as an escalation as opposed to de-escalation. So it's an interesting time to be in where there's kind of these diverging fields of we should use less, no, we should use more. Makes things interesting and probably is another hour-long discussion if you're interested.
Dr. Lillyblad, thank you very much for your time and expertise this morning. We have two questions via the Q&A pod thus far. The first comes from Dr. Ivan Chavez, who says, excellent talk, thank you. The question is regarding the use of PPI in high bleeding risk patients. Is there any evidence for increase in ischemic events in this population? We as interventionalists largely ignore the risk, if any.
I would largely ignore the risk as well. There's data. The data isn't clean. It's a lot of observational and it's a lot of points in two different directions. There's a lot of studies that say there isn't any ischemic risk and there's some that say they do. For me, I think the only plausible mechanism of reducing ischemic risk or increasing ischemic risk that I can think of is through drug-drug interactions with clopidogrel, which I am concerned about mildly with omeprazole, but not with lansoprazole or pantoprazole. So we have therapeutic alternatives to omeprazole that patients can get access to and use and eliminate the potential pharmacokinetic inhibition of activation of clopidogrel. So I would not be worried about using pantoprazole or lansoprazole in a clopidogrel patient. And once you move to like the prasugrel and ticagrelor, where there's no genetic component or issue with it, you could use pretty much any PPI in the high population. So I know that stupid alert pops up in Epic. We do not control that alert. It comes from this company called First Data Bank. And it takes hours and hours of petition to get them to change anything at the system level, unfortunately.
Thank you for that. We've got a few more here. The next one comes from Dr. Schroff. And he says, hey, Matt, great talk. Do you treat CKD and particularly ESKD any different with DAPT duration?
Yeah, the tricky thing about CKD and the dialysis patient population is while they're very much at increased ischemic risk, but they're also very much at higher bleeding risk. And so it's kind of a heck of a position to be in. Unfortunately, in these studies, I don't think we have any real kind of robust prospective data in terms of randomizing that patient population to the risk benefits of DAPT duration or intensification or anything like that. And so I would say in terms of the recommendations that I give the provider team, I don't vary based off of that, but understanding in the background that those patients are at a high risk of both. And so, yeah, it's a challenging kind of patient by patient consideration in my eyes.
Thank you for that. We have one final question in the Q&A pod, comes from Dr. Gornick. And he would be interested to see you speak again to review patients post-PCI that have an anticoagulant for stroke prophylaxis, i.e. AFib, and best strategy. So I don't know if you could speak to that.
Yeah, worth another 40 to 45 minutes. I'd be happy to hear if people want to hear it.
That's good.
Oh, God.
So yeah, that's it for the Q&A pod here.
All right, I gotta run off the rounds, but I appreciate everyone showing up and joining.